introduction. To be honest, I do not know if the session, at least my presentation, will be so thrilled. And maybe someone of you may feel disappointed with my presentation. However, I didn't want to go into hyper-physiological details or new researchers, but maybe my presentation will be slightly more philosophical. These are my conflict of interest. Well, I asked myself, what could be the future? It's a beautiful movie, a science fiction movie, that came out at the end of the 90s. Remind me something. You can see over there the two protagonists, Robin Williams and Sam Neill, that were lying on the bed in the final moment of their life, and they were fully controlled by an external energy and computer without any invasive monitoring or without any invasive thing. Is it the future? They were indeed even assisted to breathe. And the nurse there was using something very sophisticated. Maybe a quantum computer for the future, I do not know, but something like this may represent a further option for the future. Or AI, the artificial intelligence. We have spoken so much during these days about the application of artificial intelligence to the various fields. But my question is, does it work? And if we look at what has been published up to now, we have some interesting clues. For instance, in this paper that included more than 20,000 patients, the authors just focus on the use of artificial intelligence to predict prolonged mechanical ventilation and the eventual need of tracheostomy in these patients. As it happens in the artificial intelligence and the big data situations, then they inputted into the platform a number of information, in large part looking at the severity scores, looking at the physiological variables, as well as all the comorbidities presented as a number with percentage in this table. Well, they finally, at least in this publication, were capable to demonstrate that the use of artificial intelligence and machine learning for the early identification of this category of patients who may be more prone to have a prolonged mechanical ventilation and tracheostomy, showed a real effectiveness. And so something that apparently can be easily applied. In a new publication, again, in the environment of mechanical ventilation and infections, lung infections, another group focused their attention on the matching of subjective severity assessment on pneumonia and the prediction in terms of need of mechanical ventilation. This is a core study, for sure smaller than the previous one, but the authors combined together the radiological score with physiological and clinical variables. Interestingly, you can see here the sensitivity and specificity under area curve, and are quite good, 0.83, 0.71. And the author concluded that those patients who were on ventilation had significantly higher radiological score and artificial intelligence score than those that were more prone to recover and without the need of mechanical ventilation. What they have done, just adding some very relatively simple parameters such as the age, gender, white blood cell count, and the peritoneal oxygen saturation, reaching a prediction that it seems to be interesting. 0.86, 0.8, and 94, together with the RAD score. And then this could be another proposal saying, okay, this is a robust indicator and can identify easily the adverse outcome of these patients, just preventing them and focusing on the population. But there is always a but. Looking at the recent meta-analysis published a couple of years, last year, by the group coordinated by Luigi Camporota and Gallifant, they approached the artificial intelligence applied to mechanical ventilation, just preparing and elaborating a systematic review, reporting standards and biases. The studies included in these analyses were 95, and unfortunately, the vast majority of these studies, for at least one of the parameters that should address the risk of biases, has indeed at least one high risk of bias in any particular of the investigated categories in terms of device into practice model, algorithm into model, and mathematical algorithm. And the authors finally concluded the artificial intelligence applied to mechanical ventilation as limited external validation and model calibration with substantial risk of bias, significant gaps in reporting, and poor code and data variability. So, despite the potential utility, for the moment, it seems that something doesn't work as we expected. So, what can be the alternative? Maybe something that you have seen several times during these days. Identifying subtype and subpopulation where to apply the technology of the artificial intelligence. Here, coming from the big group of the ISICEM on the of the lung-safe study, were identified, thanks to the tight collaboration with Karen Calafee, and hyper and hypo-inflammatory patterns, looking at the different mediators, and finally identifying two different trajectories in terms of survival, looking at a hyper and a hypo-inflammation. So identifying a population where, analyzing the various variables, you can at least focus better the attention and personalize really the future therapy for them. Yeah, another example may come from the study focused on COVID with more than 1,000 patients, and where in the Netherlands we're capable to trace, Lubos is the first author, two different phenotypes, combining together once again the biological parameters, let's say, together with the physiological ones, such as respiratory compliance, PO2, VO2, and so on. And they identify precise trajectory over time of these two different phenotypes, looking at the clinical parameter, ventilatory ratio, PF, mechanical power, or respiratory compliance. And these obviously gave us further possibilities where the application of the artificial intelligence may be valid. And the same maybe was true for what we have done in the Italian network on the pathophysiology of the COVID-19, and where analyzing the dimer and the compliance, we could identify 4 different categories where the outcome was clearly different in terms of survival, and where the low compliance and higher D-dimer levels corresponded to the poorer outcome. And once again, also in this setting, applying a platform that exploits solid data in specific population with the artificial intelligence may be an option. Which are my conclusions, so we can give a large body to the discussion, that the future management of critical illness respiratory support still remains uncertain, and the direction of management evolution is still unclear, but physiological studies, which is another story. The artificial intelligence and quantum computers may theoretically help, but are still at their infancy phase. Don't forget that. We are just having a large and important hope on these possibilities, but still maybe are a bit premature. We need to gain experience and go better deeper into. And however, they may be helpful for identifying the RDS or acute respiratory failure phenotypes, even though no biomarkers or physiological variables per se represent to be so reliable for being a universal indicator, such as the famous Holy Grail. And the identification may also imply a better and different and personalized therapeutical intervention. But I want to conclude with my final consideration, that the physiology still counts. We live in a world where the randomized trial seems to be the gold standard. But please don't forget how much we have learned by the physiology up to now, and what we do, at least in the field of mechanical ventilation and in respiratory physiology, it's all based upon the shoulder of giants who never conducted a randomized trial, but analyzed the phenomena and try to interpret them. So the physiological principle may serve also for the future, or must serve for the future, as the foundation of the designing meaningful trials based, once again, upon physiology. Thank you.
Thank you. Thank you, Massimo. Really, really interesting. I would like to start with one question first. So, computers are capable of managing a large amount of data, right? And they can do that exceedingly fast. Do you think that the problem is not that their capability to manage these data, but to put these data into context and use properly the algorithms to use it? So, because my impression is that the artificial intelligence cannot help until it will be capable to replicate the algorithms we have in our mind. They are very, very complex. What's your thought about that?
I think that what you are depicting can be synthesized in the aphorism, garbage in, garbage out. It depends on what you put in, inside the artificial intelligence platform. If the variables and the indicators make sense, is it much more probable that in the very end they will come out with something valuable and usable at the bedside. Otherwise, we'll have something very fancy research, maybe well published, but often not usable in the real life, real clinical life. So I think that the identification with several other, as I try to show, with several other studies, can be combined with the new development related to artificial intelligence in order to achieve a more reliable goal.
Okay, thanks.